Hi, everybody. Welcome to podcast number 146. I'm Susan Clinton, one of the co-hosts, and I wanted to welcome you to this podcast. We took a little bit of time off in December and January. We hope that you all took advantage of the holidays to regroup and recharge as well. We're back with a longer podcast this week, and we hope you enjoy it. I just want a quick reminder that our website is up and www.toughtotreat.com. And also a reminder, if you listen to the two podcasts that were longer that had the slides with them, I believe they were podcast number 144 and 145. Is that correct, Erica?
I think it's 143 and 144.
Okay, in there, the two podcasts from our webinar.
Yes.
If you still want the slides, www.toughtotreat.com forward slash slides. Okay, so toughtotreat.com/slides. They're still there and you can download them at your convenience. Enjoy the podcast. Hi, everyone. Susan Clinton and Erica Mello, and we are here with podcast number 146. Welcome back to January and to 2023. Erica did some exciting travel while she was gone.
Yes, I did. I was in Vienna and Budapest, as they say.
Beautiful, beautiful city.
Yes, it was lovely.
And I'm still working on my home build out in Sault Ste. Marie, Michigan. So we're gathered back together today to bring you another version of our live podcast on a client. So today we're going to be talking a little bit about one of my clients, Erica, that I think will be great for just checking in on a couple of differentials. Mm-hmm. This is a client that I had in the past. It was a 62-year-old female that had estrogen positive breast cancer. She had it on the left side, and she had the full gamut of treatment, including chemo, surgery, and then post-surgical radiation.
Wow.
So she had the whole 9 yards, and then had to go move over to tamoxifen afterwards because she was estrogen positive, even though she was also just postmenopausal.
And she had a mastectomy, you said, Susan?
Yeah, full. Yeah.
Full. Full. Okay.
So all margins were clear, things were good so this was by the time I saw her, it was 18 months or a year and a half post all of that.
Okay.
And the reason that she came to see me was she was worried because she thought she should have more range of motion than she did. And although she was doing the exercises and the things that she had been instructed to do, she never had any lymphedema. She was wearing the sleeve though when she traveled. She was doing all the right things. She's been back to the doctor several times. There is no red flags. Everything looks very good. So, we could kind of rule all of that out as differentials. But here's the thing. She was having what she called, she said, I was making great gains because she said after surgery and then radiation, she goes, I hardly had any mobility. That she could barely lift her arm up. It hurt really bad. She just had a lot of issues in it. And she said working with physical therapy and the time, and it got better. She was able to reach her arm up about shoulder level. And she wasn't able to get her left arm behind her head, but she could do things with a towel. And, she said that she felt like she was gaining function, and she felt like that was going to continue because it had been continuing. But she said, here I am about 6 or 9 months later, and it just really hasn't changed. And I've been active. I've been trying to do things. She goes to the gym. She tries to, stretch and work out she gets in the pool and tries to move her arm around. She is not an unhealthy person. She just kind of like, for whatever reason, got stuck. The first thing that entered my mind when I was listening to the story was I thought, is it getting worse? Or is it just not going forward? So I kind of asked her to tell me the whole story because, of course, I was thinking, are we moving into kind of a frozen shoulder situation? So no pain, but it just can't get it moving.
So all motions, flexion, abduction, internal, external rotation, all limited.
Yeah. So, but she wasn't having any pain. She didn't have further pain. As she was getting better, her pain levels were going down. She goes, it's not that it hurts. She goes, I have like strong stretching feelings when I move beyond what I can do. Like it's limited because my tissue is really stiff, is the way she keeps putting it. But she said it doesn't hurt. It doesn't sting. It doesn't burn. but she did say she was having tingling in her left pinky finger and her fourth finger.
Okay.
And I said, how long has that been going on? She goes, well, interesting. The more motion I gained, the more it started to come on. And I said, do you notice it at any certain times? Mostly nighttime. So she thinks it's positional, but sometimes during the day, if she's sitting in a chair holding a book, or trying to use like knitting needles, she says it'll start to happen. So, but she feels like if she changes position and does something different. And I said, well, when you're reading a book, so show me, me, I'm always like, show me what's going on here. So she set herself up in the chair and I handed her a book and she opened it up and she put it down and she immediately put the book in her lap, down onto her legs, and she bent her head down. And I said, okay. I said, so how do you, we waited a few minutes and there, sure enough, it started to I kind of start to feel it now just a little bit. But I said, I know the range of motion of your arm is important to you, but this nerve thing is probably part of it. That's why I'm asking questions and looking at this here. I'd like to kind of just get an idea of what brings symptoms on and what doesn't. So we did, I said, show me how you knit, took the book away. It's the same thing. Her head is down mostly. Yep. So we took a couple of pillows, put them in her lap, put the book on the pillows and got her in a different position. Her head was a little straighter and her symptoms were much better. So it started making me think, okay, how much of this is involved? Is it the neck? Is it the CV junction, CT junction area? What's going on here? Is this like, let's take a look at it from this perspective, from this movement perspective, and see what we can figure out here. Or is it because the nerve roots were damaged a bit with radiation?
Or it's dural.
Lost some power, and that let's just see what we have going on here, because that's something that she could have been doing better, but over time the Walleran degeneration could have, affected her. So I had her, take her shirt off. Let's take a look at what you look like. The only thing I could see really that was different, obviously the scar tissue from the radiation, and the surgery, and the scar tissue the surgical scar went up into the axilla.
Yes.
So that's kind of important to note. She did not have any kind of
no cording
or anything, any kind of like breast tissue implants or anything like that.
So no axillary cording or anything underneath.
No axillary cording. I definitely looked for that and felt along, that the underarm and all the way down, between the biceps and the triceps there, as you can kind of get into that soft tissue in there to see, down into the forearm and things like that. No cording going on. So, but her shoulder blade was, shoulder girdle was heightened on the left side. And, so the standard question always for me is, are you left-handed or right-handed? And for her, she was right-handed. So, but she said, it's interesting that, you see that, because I look in the mirror and I wonder if I'm crooked, so it's like, well, for whatever reason, who knows? Let's look into this and see. So as she was standing there, I just asked her to take a deep breath. I just wanted to see how she coped with, big air coming in. And there was definitely a lifting of the shoulders, both shoulders up, not a whole lot of movement into the rib cage. So I kind of started thinking, maybe she's a little bit stiff there. And there would be good reasons for that with everything going on.
Yes.
So, we looked at that. I had, just for kicks and grins, I had her stand there and drop her head down towards the floor, not her whole body.
In standing.
If anything happens. She, at that point, said, I don't know if it's my fingers again, or maybe just because we set it off earlier. I said, well, pick your head back up. Let me know if it goes away. And over time it did again. So that head going down, I said, do you notice those fingers going to sleep any other time? I mean, it's very noticeable when you do your knitting and reading a book, but do you notice it any other time? She goes, not really. I guess I haven't paid attention. So that was going to be something she was going to be aware of. Because I just want to know, going up and down stairs, anytime you have your head down.
Yes, exactly. Yeah.
That would be a problem. So I was looking at kind of the differentials between dural stiffness, stiff CT region, or C8, 6 through 8, kind of nerve irritation or neuropathy or something along those lines. Is kind of like the bugaboo, but what was going to be the driver, for this? Head position seems to be a driver for the tingling.
Yeah.
And then part of it was like, okay, so what about post chemo neuropathy? Because she did have chemo and all of that, but she only had it in those two fingers,
Yeah, and
kind of like that distribution there. So you have to, and she didn't have it in her toe. She didn't have it in the other hand or on the other side. So it's like, okay, so I can there's always a possibility that you want to have that in the back of your mind, but I kind of put that to the side a little bit, thinking that's if we eliminate everything else, then maybe we have to do the Sherlock Holmes and go back to that. But I feel like that there was more to do. So when I had her, do her stuff, I had her sit on the bed, and we started with the head first, and I just had her rotate both directions. And she definitely had limitations to the left, rotating to the left. It was just harder to get over there. She could do it, she struggled, but going to the right was free and easy. When she looked down, I'd already seen that there was some hinging going on at the CT junction. Never really you never really saw like the ligamentous nuchii come out with flexion of the cervical spine. She was just kind of hinging forward and down on that. And looking up, she had fairly decent range of motion. She could knock her head up and get her chin up in the air and look up. And so, I just wanted to see what was happening there with that. And then I had her just move her shoulder blades around. I said, pretend your shoulder blades are bars of soap and they're slippery, and let's just move them around on your rib cage here, just to get like up, down, around. She could glide up. She had difficulty glide. She did not come down, as far on the left side. She could glide the right side around in all different directions and could show me. She could protract her scapula around. She had more difficulty with retraction. She tended to twist her whole side. I'm like doing this in my chair here. She tended to rotate her trunk to the left to retract her left scapula. Kind of like, inside.
Got it. Yeah.
Kind of, maybe if I move my trunk, it'll come over, that kind of thing.
Yeah.
So definitely some stickiness there, with the scapulothoracic region. And then we just looked at in sitting, we looked at, flexion, abduction, external rotation, internal rotation, reaching across the body in front, reaching across behind the body and back. What she could get to about 100 degrees of flexion. After that, I could push it a little bit, but I'll get into that story when we lay back in a minute.
Yeah.
To get to abduction, she could get to about 85, 90 degrees. And then, so if we tried any rotation from there, if she was able to bring her arm to 70 degrees, she'd have about 15 to 20 degrees of external rotation. She had fairly decent internal rotation off of 70 degrees. If she had her arm at her side, she had more external rotation and more internal rotation.
Yeah.
So you could just see that as soon as we wound up the tissue and wound up the system, that the rotational aspect of what she could do at her glenohumeral joint was limited.
Yeah.
Had her do another deep breath sitting in that position just to see if it changed, from being on her feet to sitting, and it didn't change. So I just said, just cross your arms in front and let's just rotate. So we had already rotated the head. So I said, just rotate your whole trunk around now that we were off her feet. So the hips and the knees and the feet wouldn't help the rotation. We'd have to see true trunk, a little bit more closer to trunk. And again, she had trouble rotating her head to the left, but she could rotate her trunk very nicely to the left. And going to the right, she couldn't rotate her trunk as well. So now we've kind of, getting into, okay, when she was standing up, it looked fairly even both ways. But when she sat down, you could see that, when she was going to the right, it was more problematic, which was a little puzzling to me because I expected it to be with the chest wall scar tissue. I expected it to be worse going to the left because I felt like that would stretch it more. But when you looked at her with her shoulder girdle up and, how she raised her arm, there was this constant right side bending that would go on.
Right. And
so I'm beginning now to hone in on the stiffness in that left shoulder girdle area from the neck all the way to the elbow is really taking up all the space. And whatever she's getting done, she's constantly having to, either turn to the left to do something with her right arm because she's right-handed, or she's side bending right every single time she goes to move that arm. So
got it. Yes. Okay.
anything you want to add before we move on?
No, it's just that you had just mentioned that the whole shoulder and the elbow, it sounds like to me, it is like the whole complex that you have to consider, but then I had a question about passive range, but you're going to go into that. So
I'm going to go into that. But before I lay down, I just had to do it.
Yeah.
I put my hands on the sides of her thorax and got up under her axilla just a little bit to just see if I could influence something up there.
Yeah.
See if we could make it better. And basically what I did was I just gave her, I gave her thorax just a little traction up high underneath the, the axilla. I was kind of on the sides there, just kind of coming up. My fingertips were kind of coming into underneath the pectoralis a little bit, just kind of giving her a little input in and up, just to kind of relieve any compression or things that might be going on there.
Yes.
It looked like she was compressed in there.
Oh, I would imagine she would be. Oh my God.
I tried to give her that lift, and I asked her to turn her head. It was much easier to turn her head when I did that. Left. So there is something about that, the rib cage being depressed and the shoulder girdle being held high, that conflict in that motion pattern there. It didn't really change her arm very much in that position. That's okay. Then I had to twist to the right and the left with that, and she definitely twisted both sides pretty easily.
Yeah, when you were decompressing. Yeah. There's after her surgery, has to be a lot of compression up in that area. It just scar tissue and adhesions, and the shoulder and the upper thorax were so. Even 18 months later, the shoulder and the upper thorax are so intimately related.
Yeah, 100%. And so, but kind of I didn't want to do the same thing everybody else has done. I wanted to look at her from a little bit of a different lens and see if we could find a better way in.
Yeah.
It seems like to me, at least for that component of motion of rotation of the head and the trunk, that the lifting of the thorax was really helpful.
Yeah, but it didn't make her arm better.
It didn't make her arm better, but the other stuff better. So then we laid down. And we took a look at, passive range of motion. I had her do it actively first, straight flexion, and then, abduction and some rotation. She was better with passive motion than she was with active, which makes sense. If you're fighting against restrictions, at some point the restrictions win and you just quit fighting against them. Your brain's just going to search for a better way to move or a different way to move to where you're not fighting into that all the time. And it's chosen that, that sideways lean to get done. That's just what the brain has chosen to do. So the one thing that I did do as I was looking at it, because as I noticed, is that her pectoralis muscle just didn't move well at all. And when she went out to abduction, you could see how stiff it was. You could feel the scar tissue in there for sure. And then the same thing with flexion. And so I actually just pulled her into abduction for a bit, I held her there, at that, she got to about 80, 85 laying down passively. Just held her there for a bit. And sure enough, that tingling came on in the pinky and the fourth finger again. So it's like, okay, something's getting caught somewhere. Is it at the neck? Is it as it comes through the cervical plexus, or is it coming through the axillary, the brachial plexus?
Yeah, there's a connection there.
Yeah. So what's happening there? It's either nerve root, cervical plexus, or brachial plexus, or all three. So, so one of the things that I did was I just got a hold of her pectoralis muscle. So in other words, her head is on the head of the bed. She's laying on her back.
No pillow, right?
Sitting next to her with my body facing towards her feet. So her head was close to my right trunk.
Right. And she has no pillow, like, so her head's not in flexion, right?
Right. Exactly.
Okay.
Just had her comfortable, not pulled up, not in a weird position. And all I did was reach over with my right arm and grab a hold of the pectoralis muscle. You can do it sitting in between, but I felt like that was too intrusive, sitting in between where she was not feeling good, like between her trunk and her arm.
Yeah.
So on the outside of it to come over and
Got it.
felt like I could have control there a little bit. She was more comfortable, so all I did was just kind of do some gentle mobilization of the pectoralis muscle. And basically I just kind of reached over, grabbed it, did some lifting and relaxing. And I did it in various stages of abduction. So I'm going either after soft tissue, the nerves, neural tension, or all three. At that point, it didn't matter. I just wanted to see what could happen there. And she gained range of motion as we went. She really did. Just as we kind of went and unloaded that neural system, just like unloading in the thorax by lifting up. As we unloaded that neural system, and I could get a hold of the pectoralis and lift it and get it moving, and bring her into various, angles of abduction, as well as like scaption angles, so it wouldn't just be out to the side where it was the hardest. I was looking to unload that neural system and see if we could get her moving better, and not straining with the movement. She gained some external rotation with that. And we were able to do those motions without her fingers, coming on. So as soon as we got into where it was really stiff and tight, and if she stayed there for any length of time, like over 2 minutes, that's when it would start again. So it was, I would have to say it wasn't terribly irritable, but it was irritable enough that, the wrong position for any piece of time longer than 2 to 5 minutes would bring that on.
Right.
So that's pretty quick. It's not like the ones that come on as soon as they move a certain way and it fires off down their arm. So thinking about that, do you have any other questions?
Yeah, I have a question. So I have a bunch of questions. I'm just thinking, because you're answering them as you're talking. So in terms of like I'll ask the very basic question. In terms of the end feel, right, of her shoulder motions, what do you think it was?
Yeah, so we weren't getting into any kind of capsular infill.
That's my question.
Yeah, okay. It was definitely soft tissue.
Yes. Okay.
Restricted infill. Like you could just see it too. You can see that we were at the length of the soft tissue.
Right.
Got
it. Okay. And from a clinical reasoning perspective, then, do you think, so, you've done the whole, obviously, history and probably most of the exam, just for the listeners, do you think that the impairment, like not so much the driver, but the impairment, was it a loss of length of neural tissue, or a loss of length, it could be all, of muscular, or was it something else, I guess is my question. So
one of the differentials I was looking at was thinking about, was there some dural stiffness or dural restriction in there? That with the head piece.
Yes.
Yeah. So my thoughts, my hypothesis was continuing to, so that was a secondary thing to snuff out. But my hypothesis moving along was soft tissue restrictions, including neural. So, and then as soon as I started decompressing the areas, started getting better motion. So she got kind of caught in, I think, a little bit of a protective loop. Plus, she also got caught in a loop where even 6 months to a year post radiation, you can still tighten up.
Oh, yeah.
And, and she was, so I just felt like what she needed more strategies to help her tissue lengthen and become, we're not going to change scar tissue, but to allow the scar tissue to have more freedom of movement,
more options,
and the shoulder girdle area. So the scar tissue became the driver here with me.
Yeah, interesting.
Yeah, it's like the shoulder girdle itself is being pulled by the scar tissue.
Right. So I was thinking, because you often see patients who are scap elevated, scap retracted, serratus tight. But was that just of the victim? Was that a victim posture? It sounds like it was, versus a driving posture. Right.
And I think first got stood up by pain, and then, eventually, of course, became fibrotic, because that's what happens to these tissues with surgery and everything else. So we just started working on a couple of things. But before we go any further with kind of how I progressed her, one of the things that I did was I decided that I was, since decompression of the thorax felt good, I thought, what if we get a towel roll, and while she's laying here and I'm working on her arm, we put it underneath her T1, C7 region, just to see if we can gain a little mobility there.
Yeah. Like self-traction.
Yeah. So we did that, while we were working on the other stuff, just to kind of, I told her, I said, not sure if this is really going to help, because it was just everything so caught up together. But while we're here for a few minutes, let's just try it and see if this makes a difference. After we did that, I had her sit back up, I said, just move your arm. It was a little easier to move her arm. I got back under her trunk to give her that lift. It was still easier to move her arm, and her trunk was a little freer for rotation again. So then I just let everything go, and I told her to drop her head down. It still took it took probably a little bit longer for the tingling to come on, but it did. So what I had to do was come back up. We relaxed, we did some breathing, and just talked a little bit more. And then I came up under her trunk again, to do that elevation through there, and then had her drop her head. And she was so much more comfortable.
There's something in that pathway, I would say, dural, whatever you want to call it. But it's interesting, because sometimes when I have patients who have that issue and they're in supine, I'll do the towel thing, but I'll also have them I'm just do like we call retraction of the scapula, like retract their arm up and retract their arm down, like they're reaching for the ceiling, and that somehow helps them decompress the upper thoracic spine as well.
You mean protraction of the scapula?
Protraction, sorry.
Yeah.
Gosh.
Yeah. That's okay. I'm watching you. Nobody else is. So.
I know. I'm protracting and I'm saying retracting. Protraction.
Yeah. So, but that's good. I'm glad you brought that up, because that's exactly where I decided that we were going to drive the intervention. So
good.
Things first, I taught her how to mobilize her scar tissue and her axilla, and how to mobilize her pectoralis by just reaching over and getting under it. Get your hand comfortable on a countertop. And just move it, just pick up that tissue and move it and wiggle it around in all kinds of different positions. Take a deep breath in and move it, let it out and move it, move your body around with it, so she could kind of start getting into that area a little bit herself. And then we did the trick that you've talked about before. Got the 2 small Franklin balls. And put them right up into her axilla. It's going to help her, the system, the tissue that isn't scarred, move better with the scar tissue. And we just, we did some breathing exercises in that position, and it was comfortable to her because it was actually elevating her thorax a little bit, so she wasn't pulled into this stuff all the time. And I said, this might even be more comfortable sitting in a chair. So we sat in a chair and put, like a folded dense blanket behind her, so she had some spinal support. And now you can just kind of work your shoulders up and down and around and take some breaths. This might be something that you can do. You can do it in a variety of positions. I didn't want her to just be stuck in standing or laying on her back. A fairly active person. So that's what she went home with. Then as she came back, it was time to actually start adding movement into this, decompression thing here that we had going on. So there were 2 goals or objectives that I really wanted to see if they would work with her. And one was, what kind of input to the thorax do we need for the range of motion to change? To this point, she's been doing some wall stretches, but she hasn't really been doing any type of closed chain movement. She was mostly open chain and grabbing something to stretch it, things like that. So I really wanted to see what closed chain would do. If we got her fixed distally, would she open up proximally? Was kind of the deal. So here we go to the wall, when their hands on the wall, and beginning to, especially we started off with 2, because I just wanted her to get the idea of some breathing and some chest expansion in that position, sliding the arms up on the wall a little bit, sliding them down, sliding them wide, like we talk about wide and narrow, making some circles on the wall, but not big. Didn't want to challenge the range of motion so much as I wanted to continue to open the trunk area, decompress that upper thorax as much as possible. And then we went to one arm where she could keep the arm on the wall, but instead of like planting the arm and stretching her body, I wanted her to just do things like pushing. Just do like a little mini press into the wall. Like, can you lean into your arm and come out? Like press in, like the small push-ups or press things like that. We did that in various positions. Same thing on countertops, like the bed, putting her hand down on the bed. I wanted to get her inverted as much as I could. So the bed was a little squishy, so we went to the chair, and I said, just put your hands on the arms of the chair. And I want you to just kind of let your trunk go, let it relax, and just, do some easy pushing into the chair, push up and back. So we worked on things like that to help her, because again, decompression was still the name of the game.
Yeah, but also it got her head down in that position too.
Yeah, we got her head down, but she was in a position to where her trunk would automatically like decompress because of the position.
Right, exactly. Yeah.
Rather than trying to do so much of overhead, which would not have been well. And that's what she was doing. She was trying to crank her arm overhead all the time. And so that was further compressing her thorax in the top. And until even we got some nerve root irritation,
Yeah. She plateaued with the traditional, which was needed, obviously, but then you need to look somewhere else after that.
Yeah, and then with the right side bending on top of it, so that was the other piece of having both arms on the wall first, was to stop that right side bending.
Yes, exactly. 4-point or 2-point. Yeah,
exactly. And so she was fine getting on hands and knees, and of course we did that, and it was easy for me to get underneath and mobilize the axillaries. She kind of rocked back and forth onto her arms, like towards child pose and back up, so those were the ones we concentrated on for the first few weeks of treatment. Was that my goal was decompress the upper trunk while we get range of motion and mobility back in a different way. And, and not have that nerve root irritation come off. That nerve root irritation comes on, I know one of two things. Either it's at that CT junction with the head dropping, or that trunk is getting compressed.
Yeah.
So we talked about setting herself up for her activities in the short run, so that wouldn't come on. So that she could, when you go up the stairs, lift your eyes up, instead of looking at your feet when you're coming down the stairs, glance at your feet but don't stare at them. Just to kind of switch it up a little bit, the same thing with reading on the computer. She went and got glasses that refracted her for the computer so that she wouldn't put her head in a funny position to squint at a razor font level, screen, so she could read easier. Same thing on her Kindle. It's like, just you don't have to challenge yourself and struggle to read. Just easy.
Make the font bigger.
Brain energy is going towards trying to squint and read. Like, bring the letters up where you can see them easily. Relax and have fun with it.
Yep.
And then then we eventually moved to open chain, and so that was going to be kind of where you have a lot of input that you would add in there too, but we started open chain in supine.
Yeah, that's where I would have started.
She needed the scapular support, and then we took that to where her back was against the wall. For open chain, for some open chain movement. And of all things, like crazy, I just had her sit in a chair and do basic rows with the TheraBand, like just kind of pulling back, but both hands, both arms, both shoulder blades.
Yes.
And what position do you need to get in so that little tingling doesn't come on? And she did better with when she was like in good posture. She could tell as soon as she started to slump and got lazy, she would start to feel the tingling a little bit, which made a lot of sense. We'd be falling back into compression.
And it's interesting because the thorax is 360, right? It's not just right, left in AP, but it's 360. And, with her, she literally was 360, the compression and the AP. And that's, do you have anything more to add, or do you want me to?
No, I think, this is where we ended it. She actually got to the point where she could raise her arm. She gained back to 150, maybe 155.
Oh, that's fantastic.
Overhead. Yeah. So that changed her world. Yeah. She gained enough external rotation to be able to get to the back of her head. She was able to close on so much easier. She just felt like she was freeing up. And, she was more confident to lean forward. This is the things, when you do some of that closed chain work, she felt like she had the confidence to ride her bicycle. She wasn't because she just wasn't riding her bicycle, but she didn't know why. until we got her, where she was doing more of this stuff. And she goes, when we were doing some of that, lean over, pressing in issues, she goes, this is just like being on my bike. And I said, when was the last time you were on your bike? And she said, over 2 years ago. It's like,
and it's so, and
about sitting on your bike at home.
Yeah. And closed chain is hard for the neck, the thorax, and the shoulder. So you get 3 birds there, in one stone, so to speak, that's great. I mean, I love that story because I think a lot of and you did that without manipulating the shoulder, without cranking on the shoulder, without hurting the person, because people, with frozen, if she had been misdiagnosed as a frozen shoulder, that would have been a disaster because she would have not gotten better. I mean, she needed what she needed to have done at the beginning, obviously, but I think that for the listeners, because of how she presented and just because of her story, right? Just her story alone, you're thinking it cannot just be the shoulder. There's no way. And
you have to check the shoulder. Like I checked, I checked joint mobility.
Yeah, of course.
But it wasn't the joint mobility wasn't bad. I could move the joint around. The joint was becoming compressed because of the way that the tissue was holding the movement back.
Exactly. And if she did not have the surgery, you would say, well, it's probably an old movement pattern, but she did have surgery and the consequential radiation and chemo that invoked changes in the thorax. It just does. Mm-hmm. And because of that, she'll unconsciously guard, and obviously it was one-sided on her, but you have to think about, well, okay, what can I do to sort of let's prove my hypothesis wrong. Let's prove that it's not that. Yeah. And so I will say that with patients who have issues with their thorax, open and closed chain, you need to do both, which is what you did, because you can do, and especially with someone like that, she's lost her sense of center, literally, right?
Literally.
So yeah, exactly. So you training that in supine and then going into center, you said she had her back against the wall. Did you say that as well? I think I do that a lot too, because I have to put both butt cheeks on the wall. And I'm like, if you feel one butt cheek coming off the wall, you've lost center, because some people have no idea where their center is. So you try to give them some tactile, right? So
and the doorknob squats and midline orientation piece with movements. All be very helpful for this type of thing as well.
Awesome. It's a great case. Lovely, Susan. Thank you so much for sharing.
Okay. Yeah. All right, everybody. Episode 146 is in the books. Look forward to your feedback. Please join our newsletter. That's where you get all the latest information. And again, if you wanted to get the slides from the last 2 longer podcasts that we did, toughtotreat.com/slides. Thank you.
Bye.